Welcome everyone to today's webinar, Redesigning Acute Pain Management to Provide Quality Patient Care. I am Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Jimmy Bergelli is Director of Clinical Integration at Beth Israel Deaconess Hospital-Plymouth. He is an experienced clinical director with a demonstrated history of working in the hospital and healthcare industry and is skilled in healthcare consulting, clinical research, medicine, advanced cardiac life support, and patient safety. He is a strong business development professional with an RPH and MS focus in clinical pharmacy from Northeastern University. Jimmy, I'll now turn the floor over to you.
Well, thank you very much, Ayla. I appreciate the introduction, and I would like to take this time to thank the folks from Allen Crott for sponsoring my presentation today, as well as the folks from Becker's for putting together another fine topic. I gave a presentation like this a year ago, which was, this is a topic very near and dear to my heart. Everybody is touched by somebody with opioid or substance use disorder, and our goal here is to redefine how we treat pain. So just this photo right here, I want you to take a look at Beth Israel Deaconess Hospital in Plymouth, and this is and for most of you who practice near the water, you probably are in the same boat as I am, that I usually get here when it's dark and I go home when it's dark, so very rare do I see the water. And especially today, once I leave the presentation, I have to go home and turn on my snow blower. We received about 5 inches of snow, so it really doesn't look like that today. Just a little bit about BID-Plymouth. We're part of the Beth Israel Deaconess Medical Center Health System. There are 2 other community hospitals, BID Needham and BID Milton. We're soon to be a extraordinary large health system as of March 1st, which will be merging with the Leahy Hospital system. Will be 13 hospitals rivaling our partners' healthcare. So it's very exciting to be in a big system. And the things that we're really proud of here in Plymouth is that Leapfrog designated us as a top general hospital in 2016. We were only one of 2 general hospitals in Massachusetts. And in 2017, we were the only hospital in Massachusetts to repeat 2 years in a row. Unfortunately, we didn't repeat in 18, but our goal is to restart that process again. So we're very fortunate to have an extraordinary group of physicians that collaborate with us and are really willing to sit at the table and help us through many of the disease states and clinical pathways that we put together. So very fortunate to work with such a group of extraordinary individuals here in Plymouth. A little bit about so we want to get through, how we're going to redesign the management of acute pain, utilizing multimodal analgesia as a foundation. And, in years past, the opioid overdose epidemic was in the news every single day. You couldn't get away with radio broadcasts or news on the TV without seeing things about the opioid crisis. Still, it's there, but not as prominent as it was in the past. So just looking at, you can look at, I have some data here from the CDC website. In this data, the data is published in December of each year. If you look at the last block of data, this came out in December of 2018 with the 2017 data. And you can look at, on CDC, you can find all kinds of charts and graphs of where folks are getting their opioids, the prescribing of opioids. But this is looking at the overdose, drug overdose death rate. And as you can see from 2015 to 2017, we've put an extraordinary amount of information together at all of the hospitals in the country, looking at, utilizing non-opioid analgesics and reducing the prescribing of opioids. But as you can see, the total overdose deaths have still increased from 52,000 to 70,000 in 2017. And overwhelmingly, the opioid-related deaths from 63% in 15 all the way up to 67%, or almost 68% in from 15 to 17. Now, granted, the majority of these opioid-related deaths in 2017 are from the illicit drugs like fentanyl and heroin. Yet, if you look down below, past misuse of opioid prescriptions are really the significant risk factor for heroin and illicit drug use. As you can see over in 2017, the top 10 hospitals had a rate of, in West Virginia, from 57.8 deaths per 100,000 down to Massachusetts, which is 31.8. In Massachusetts, as I can say, I've been on some of these task forces, and we've once again put an extraordinary amount of effort into decreasing and diffusing this issue. But as you can see, we still have a long way to go. The CDC is actually really concerned about their data lagging a year behind, and they're looking forward to try to update that data to get the 2018 data a lot sooner than December of 2019. Looking at these rates, these are the top 10 age-adjusted death rates. If you look at the bottom four are kind of right dead center in the United States. North Dakota at 9.2, South Dakota 8.5, Nebraska at 8.1, and Texas at 10.5. Can't tell you why the death rate is so low in the middle of the United States, but that's just kind of the way the data falls. But we still have a long way to go. Some of the impressive data that has come out is the American Medical Association Opioid Task Force presented at their 2018 progress report in June. In that progress report, they identified that from 2013 to 2017, we've decreased opioid prescriptions by 22% across the country, and every state has decreased their opioid prescriptions. This is a decrease of about 55 million opioid prescriptions. So, as you can see, although some of this data is disheartening, there are some task forces that are uncovering data that really is promising that we are making that move from utilizing opioids for pain management to multimodal analgesia. So as we look at the quality landscape, how can we change in that quality landscape, and manage our pain and change the way we have been trained to treat pain for our entire careers. And so the evolving paradigm for patient care, or patient-centered care, started out with the Affordable Care Act in 2010. Now, theoretically, we were supposed to be utilizing patient-centered care well before that. But with the Affordable Care Act, as you can see here, with improved value, quality and safety, and the experience of care, and the HCAHPS scores, this is mimicking the triple aim. And the triple aim from the Affordable Care Act was better health care, and better value. Critically important is that those HCAHPS scores and what patients are perceiving as our treatment of pain. Now, looking at the Affordable Care Act, it developed a lot of accountable care organizations, and the only way we can really move forward is moving from a volume-based purchasing or fee-for-service to value-based purchasing. So money is being used to incentivize us as the quality of care that we're delivering. And I've worked on committees and been the chair of developing clinical pathways for over 20 years. And prior to the Affordable Care Act, when we developed clinical pathways, we really didn't care where you came from or where you were going. It was once you hit the emergency department, all of the plan of care was put in place, the pathway was put in place until discharge. Now with the value-based purchasing and the accountable care organizations, we have to take care of patients across the continuum of care. So we really do care, if the clinical pathway should start in the PCP's office and go all the way through disposition at the end. So Medicare payment and reform, Well, ultimately, the only way to get that patient in the center of care and to assure that we're delivering that care is to incentivize us, as CMS has told us, that we're being incentivized. We're with withholding of certain percentages depending on what we're looking at for reimbursement. So in 2019, there's a 3% incentive for readmission rate. There's a 1% incentive for hospital-acquired conditions, and 2% is withheld for value-based purchasing. So many institutions, we can look at that as an incentive or as a penalty. And so as we found in the past, the only way to truly establish quality of care is to offer these incentives in order for us to do the right thing. So as we're looking at the treatment of pain, we want to make sure that we're providing the best quality in order to achieve the maximal reimbursement and the best quality of care. Now, this study was done looking at readmission rates. And so, I'm sure many of you, and when you're looking at readmission rates in your utilization review committees, you're focusing on heart failure and COPD. I sit on those committees myself. But we really have to assure that as we're treating pain that, are we increasing that 30-day readmission rate by the way we are treating pain? And in this particular study was done by T.J. Gann, who's the chair of anesthesia at Stony Brook in New York. This was completed in 2015. And as you can see, what they looked at is the relationship of the median morphine equivalent doses administered to patients. And they looked at premier data and about 138,000 patients from 2008 to 2010, and they looked at abdominal procedures of open and laparoscopic colectomies as well as open and laparoscopic cholecystectomies. Looking at what was the relationship between the amount of morphine, the morphine equivalent doses given to these patients and the readmission rate. So what they did find was that there was no real statistical difference in patients for readmission if they were given above or below the 270 morphine equivalents for open cholecystectomy. But what was intriguing is that if you look at open colectomies, laparoscopic colectomies, and laparoscopic cholecystectomies, that for those patients who received above the median of the opioid equivalents, had a higher readmission rate. And you can see in each one of these instances, the readmission rate was significant. And these are because as you all know, that opioids and these type of procedures are prone to ileus, and those patients that developed ileus from receiving larger doses of opioids, their readmission rate was obviously higher. And to go along with this, the length of stay for these particular patients was longer also. So as you know, staying in the hospital longer increases the cost of care for that patient. These complications of readmission rates would ultimately be an issue when we're looking at meeting that quality indicator for the reimbursement from Medicare. So there is an incentive for all of us to utilize using non-opioid analgesics as well as non-pharmacologic methods of treating pain. So that being said, moving on to the patient's experience or the HCAHPS scores. Well, you're all familiar with the HCAHPS scores, I'm sure, in that in most of your hospitals, I'm sure there are the quarterly reports hanging in all of the patient care areas and how we're doing and where we need to improve. It's all over the hospital here in Plymouth. From the Affordable Care Act in 2010, which seems years ago currently, that they started utilizing the HCAHPS scores as part of value-based purchasing in 2012. Now that the value-based purchasing was in the HCAHPS was about 25% of the overall calculation for that 2% that we're looking at for value-based purchasing. The other percentages were for outcomes, efficiency and decreased cost, as well as safety. So the important issue around the HCAHPS scores is it gave a platform for us to look at the patient's perspectives or their perception of how we're delivering the pain relief how we're delivering care to the patient. It's a public reporting to improve quality of care. Obviously, if it's publicly reported that patients are going online and looking at what the HCAHPS scores are at particular institutions, and this transparency and accountability makes us all want to have higher scores. So not only are we reimbursed, but we're, to the public, they can identify with us as a high quality institution. Now, these are the 8 domains that you're familiar with of communication with doctors and nurses: responsiveness of staff, cleanliness, communications about medications, discharge info, care transition, overall rating. And as you know, pain management is one of the major components. The issue with the pain management is that it was brought forward by physicians in 2016 at the American Medical Association annual meeting, is that they felt that they were being pressured to order opioids for patients. Now, as I said, pain management being part of the HCAHPS scores, which is 25% of the value-based purchasing, they felt that they didn't order or prescribe opioids for their patients, the patients would give them a terrible HCAHPS score, which would ultimately reduce reimbursement to the hospital. So this went through many iterations, and this was looked at by CMS and taken under consideration, and ultimately changes were made due to this advocacy to remove those questions as part of the value-based purchasing score. So in January of this past year of 2018, the questions were removed from the value-based purchasing score in order to not give that perception that providers thought that they had to order opioids. But ultimately, as we moved forward, that they decided to change the questions from pain management, as you can see on the left here, to communication about pain. And as you can see, that the changes in the questions were, did you need pain medicine for pain? And the newer questions, which were in January of 18, were, did you have any questions communicating, did you have any pain? During this, hospital say, how often was your pain well controlled? Whereas, how often did hospital staff talk to you about your pain? And finally, this is the most difficult one in the past, was how often did the hospital staff do everything they could to help you with your pain? And they changed that to, how often did the hospital staff talk to you about your pain? Now, looking at this, the difference between the management questions and the communication questions, there was still a strong feeling that physicians were still being pressured, and they were still bringing forward to the president's, the Washington Opioid Task Force. So ultimately, these questions will be removed altogether from public reporting. We still will be able to get these reports, but the public will not see these efforts on HCAHPS scores, but we all in our hospital will be able to utilize those. And you'll see down the road, we review our HCAHPS scores at every single one of our pain stewardship meetings. That being said, there was a study done by Anita Gupta back in 2009 looking at HCAHPS scores, and what she found out with this particular score is that if patient's pain is well controlled and decrease of adverse events, that the patient scored all of the other domains really high. And if you just think about it, it makes really, really perfect sense, is that if I'm a patient lying in bed and my pain is not controlled, I feel like I'm in agony, no matter what the communication from doctors, nurses, or anything else that we're doing for that patient, they're going to give terrible scores on the HCAHPS scores if their pain is not well controlled. So this, once again, makes perfect sense as to, how can we control that pain, decrease our opioid utilization, decrease adverse events, and ultimately have the patient focus on the quality of care that we're delivering at each site. So now with the Affordable Care Act again and the accountable care organizations, how do we manage through that? And looking through the continuum of care, that once again, I think what we have to look at is developing clinical pathways and standardizing that care from the physician's office, as I stated before, all the way through disposition. And that entails what are we doing for the patient when they're at home? Are they home with services? Or are they at a skilled nursing facility, and what does that look like? And once again, we want to manage quality, safety, and cost of care. And what are the elements that we really measure and monitor within the hospital? Well, usually length of stay, discharge to the appropriate site of care. You know, if we can manage keeping the patient one more day in the hospital rather than send them to a skilled nursing facility, that's probably more appropriate than sending them to a skilled nursing facility where they may stay for 15 to 30 days when they only need to stay there for maybe a few days. We look at that readmission rate and adverse events, and ultimately, how can we develop pain management protocols in order to manage this redesign? Well, this study is looking at the current state of pain management, and there are multiple studies. This one was published in 2015. There are multiple studies that are out there today. In this study, which was a compilation of 20 years worth of studies that were accomplished looking at patients' perception of their pain management following a procedure. So this study encompassed in 1995 Carol Warfield, who actually was in charge of anesthesia at Beth Israel Deaconess Medical Center in Boston. What they did initially, as you can see down below, is that they surveyed 500 patients, and all three of these studies were similar, the one in 2003 and the 2014 one, once again by T.J. Gann. They looked at approximately 1,000 patients over these three studies, and what they asked is that each one of these patients within the last 5 years, if they've had a surgical procedure, and what was their perception of postoperative pain. Now, I'll be lucky if I can find my car when I leave here, but every 5 years seems like an awful long time for these patients to recall exactly what their pain management was at that time. The average amount of time that the patients had procedures was about 14 months. And as you can see from each one of these studies is that they ultimately reported moderate, 45 to 49% moderate pain to extreme pain postoperatively 8 to 18%. And this is through all three of the studies. And so the take-home message here is from this over 20-year period, 1995 to 2014. Once again, we've put lots of protocols and pathways in place in order to treat pain, decrease opioid adverse events. We're still not quite there yet, and you know, there's a lot of work to do in order to have patients' perception of pain be that it is well controlled, and that and to educate the patients again that you will have tolerable pain, and I think that's one of the missteps that we make. Another caveat of this study from 2014 was that, you know, a high percentage of patients, when asked whether they would rather have non-opioid or opioid medications, it was over 50% of these patients that had selected that they would like non-opioid analgesics in order to treat their pain. So folks really are, you know, are in the literature or in the news listening to those adverse events that we see from opioid analgesics. Another good study that was done by Laura Pizzi in 2012, she was at Thomas Jefferson in Pennsylvania, and this is an excellent study which looks at balancing pain management and the effect on adverse drug reactions. So what they did is they took, this was all orthopedic patients, about 400 patients, 100 knees, hips, shoulders, and spines. And what they did is that they took all of the opioids that they received and reduced those to morphine equivalents, which were equivalent to about 60 milligrams of morphine equivalents a day postoperatively. And they looked at the number of adverse events that each one of these patients had. And what they discovered was that 54% of these patients had at least one adverse drug reaction from the opioids that they received. 26% had at least 2 adverse drug reactions, and 7% had at least 3 adverse drug reactions from the medications that they received. And if you look a little bit more closely at the data, is that the composite of nausea and vomiting for this patient population was about 36%. And for emesis, 13% of these patients had vomited at least once, 4% of them had confusion, and 7% had constipation. Now, looking at the the mean days without an adverse drug event, which was about 3 days for all of those patients, compared to those patients who did have an adverse drug event, right? You can see that the increase in the length of stay. You know, for emesis, it was about 0.7 days, increased length of stay, 1.1 days for confusion, and 1.4 days with constipation. Now, take any number you want for a day in a med-surg bed. $2,300 is kind of like that HCAHPS score value for a community hospital. You can go anything from $2,000 to $3,000, or even if the patient was in an intensive care bed, even more dollars. But look at, you know, if you're extending a patient's length of stay by, you have 100 patients that you're extending their stay by 1 day, and it's $2,300. That's a significant amount of money just by giving opioid. And for all of you that have practiced for a number of years like myself, all I recall way back when in our PACU was treating nausea and vomiting in our PACUs. And when Zofran first came out, that we could not use Zofran because it was so costly in the PACU, but everybody had nausea and vomiting from all of the opioids that they had received. So we're accustomed to the way we were trained is to treat with opioid, you know, give them an oral opioid, or then switch to injectable if there's more pain, and then increase the dose of injectable opioid if there is more pain. But ultimately, you can see this is the price that we pay on the other end from continuing to utilize the same agents with adverse outcomes. So what are the benefits of multimodal analgesia? This is so well documented in the literature that you know, this is just highlighting some of that. And you know, we can see that we get better pain relief with you know, dual agents than a single agent, and we're getting that synergistic effect with multiple agents added in that plan. We'll talk about that a little more next couple of slides. We're reducing the doses of analgesics in the treatment plan, and theoretically, where most organizations misstep is that when we utilize non-opioid analgesics, we should be reducing the initial doses of opioids that we give those patients. When they go from mild pain to more moderate pain, that we should not be giving the same doses, or we should decrease those doses. So ultimately, if we have an opioid dose reducing effect from multimodal analgesia, we'll also have decreased adverse events. There are fewer analgesic gaps because the recommendation for a lot of these agents, these non-opioid analgesics, is to give them scheduled around the clock. We improve functional outcomes, and if we're improving functional outcomes, patients that are having orthopedic surgery or any type of surgery, they're ready the same day of surgery to get up and move around with physical therapy. And ultimately, there are a lot of total knees, total hips that will be done same day, and patients are going home within 24 hours. So if you have less pain during rest and activity, you reduce your length of stay, and ultimately, as I said before, we increase our patient satisfaction. So therefore, you know, as I said, developing clinical pathways, we always look at the most current evidence-based guideline, and you know, where are those guidelines coming from? There are several organizations and there are many more that support multimodal analgesia, and it's widely endorsed. And you know, ultimately, if it's widely endorsed, we should be utilizing this in our order sets and the way we treat our patients preoperatively, you know, in the surgical setting. But we should not be forgetting those that are medical patients. You know, when the elderly geriatric patients comes into the ED, you know, should we be giving those opioids? So there's a thought process that we'll talk about also, is that, you know, ultimately those patients don't need 1 milligram or 2 of morphine in the ED. Maybe they need another agent, a non-steroidal or acetaminophen to treat that pain in the ED. So looking at these not only the medical societies and nursing societies that support multimodal analgesia, you know, you have to look at ARC as well as the Joint Commission, you know, who are highly supporting it, and it's evidenced by the increase in their new standards. So looking more closely at that evidence of support, the Joint Commission in 2012, I'm sure you've all seen the Sentinel event alert of utilizing opioids within the hospital. That was a guideline that we utilized for a long period of time. We identified high-risk patients for adverse events from opioids. There's a good chart in that particular document. 2015, another sentinel event alert was aimed at preventing falls and reducing these contributing risk factors of opioids. And ultimately, this is kind of the big goal that we were talking about, is that in January 1st of 2018, Joint Commission initiated a new pain management standard, which ultimately supported the use of or the formation of pain stewardship committees, or those type of committees within the hospital. CMS, obviously, along the way has been advocating sending a memo in 2014 for increased risk assessment and monitoring for IV opioids. 2017, another opioid misuse strategy, which supported the use of non-opioids. And in 18, once again, just reiterating the changing in the HCAHPS questionnaire. And then finally, the Institute of Safe Medication Practices, always sending out those high alert notifications around opioids. So multimodal techniques, what are the techniques in the perioperative pain management? Well, as I stated before, it's combining two or more agents to act at different mechanisms to provide analgesia. When I talk about this to my PharmD students, it's almost like treating hypertension. We're utilizing, antiarrhythmics as well as diuretics, different agents in order to reduce the pump issue, as well as antimicrobial therapy when we're utilizing one or two different agents when we're treating Pseudomonas to treat different sites in the cell. Same thing with treating pain, that we're looking at more than one agent along that pain pathway in order to reduce the amount of pain. The American Society of Anesthesiologists, they sent their guideline out in 1994. They updated it in 2004 and finally in 2012, advocating for, unless contraindicated, that we should give non-opioid analgesics scheduled around the clock. And that being said, is that along with this, and for surgical procedures, to consider regional blocks, and the regional blocks along with the non-opioids has drastically reduced the amount of opioids required to treat pain in the postoperative period. So looking at the sites of action of these agents in the periphery, we see the local anesthetics like bupivacaine, liposomal bupivacaine, the non-steroidals, the COX-2 inhibitors like Celebrex, gabapentinoids, Lyrica and gabapentin. As we move up into the dorsal horn more centrally, we see the local anesthetics again, along with the opioids and the alpha agonists such as clonidine and Precedex works in this particular area, and the NMDA antagonists, which are this is ketamine as well as magnesium ions. We have a general surgeon who puts magnesium in, so depending on the patient population, will add some magnesium to the IV infusions in order to assist with pain management. And then essentially all of these agents work centrally, and here's where we add acetaminophen also works centrally. So as I said before, that we're adding different agents along that continuum of the pain pathway. And once again, just reiterating those agents as we stated before. So this is the old paradigm on the left, as I stated before, is that when we're looking at mild, moderate, and severe pain, this is the old analgesic pyramid. And so traditionally, as I stated before, we'd give PO opioids for a patient with mild pain, so with a pain scale of 1 to 3. And we increase it to injectable opioids from 4 to 7 and 4 to 6 and 8 to 10. We'll probably increase the dose of injectable opioid or slap a fentanyl patch on them at the same time. So you can see how this is fraught with we're leaning towards many adverse events, all the way up through respiratory depression for patients in this particular instance. As we look at the new paradigm in multimodal analgesia, looking from the guidelines that we've just referred to, that step 1, mild pain, we have to teach our patients that mild pain is tolerable pain. in our order sets, which I'll show you in a couple of slides, we had opioid analgesics for a mild pain of 1 to 3. We've taken away all of our opioids for a mild pain scoring. We should be using acetaminophen, nonsteroidals, the COX-2s, as I stated, as well as local and regional anesthesia. Moderate pain, we can step up. You still utilize these doses and it's scheduled around the clock. And we add low doses of opioids, as I said. Low doses, and you'll get away with, in many instances, with controlling the pain. And then ultimately, we have to look at some nerve blocks, and there are patients who are in severe pain, and this is where we may increase the doses of our opioid analgesics. So now non-opioids is a foundation for acute pain management. What are those considerations? Well, multimodal analgesia, we still have to be cognizant, as we're adding these type of agents and be monitoring them because, every class of medications is fraught with adverse events, and we have to monitor them closely. So we have to look at the efficacy of all of these agents, special patients' characteristic, age. There are certain, the non-steroidals, ketorolac, a certain age, we have to decrease the dose for those patients. We have to look at organ dysfunction, renal dysfunction. We monitor that for all of our medications, and ultimately we might have to reduce the dose of medications as well as the frequency of administration are not even indicated for those particular patients. Gastric motility is very important to monitor. The stresses of surgery. Sometimes if we give oral agents for surgery, they're not well absorbed, and we have to make sure that the gut is working in order to utilize these oral agents. In some of the instances, as you see with our pre- and post-operative order sets, we may give some of these agents by injection until we're assured that the gastric emptying is working well in order to give these oral agents so that they will be absorbed. Make sure that we're giving these agents around the clock, and then ultimately, you'll hear this several times, is that we have to focus on acquisition cost versus global value. In many instances, a lot of these multimodal agents or these non-opioid agents are more costly than giving 1 or 2 milligrams of 1 milligram IV of hydromorphone, as well as a milligram IV of morphine. Some of the oral agents that we use are much more costly, but we have to learn how to utilize those agents and really how to restrict those agents appropriately to be given to the right patient. So how do we redesign our pain management plan? Well, looking in as you'll see, we really took this on as, from Mass Hospital Association, I'll get into this in a minute, is that trying to teach practitioners who have been trained one way for many, many, many years is very difficult. But, this is a critical point in how we will get past this overutilization of opioids. So we have to understand that there is a balance of optimal pain management as well as adverse events. Once again, we have to justify acquisition costs with global value. And this is one of the important factors where many organizations fall down, that they will choose not to use the most appropriate agent because they don't have the ability to restrict that particular agent. We should be standardizing across all of our systems. We should develop clinical pathways, whether it's a postoperative pathway, whether it's an admission pathway for pain, develop those order sets to control utilization of these agents. So as I said, pre- and postoperative order sets, adult and geriatric pain modules. So we don't forget our geriatric patients. There should be a reduction in those pain modules. Maybe it's a pain module for patients that are in the emergency department as well as those that are admitted. And don't forget our clinical pharmacist. Being in charge of the clinical pharmacist here myself, I have to advocate that they are one of your most important resources that many organizations, as I said, would not utilize an agent unless they should be incorporating the utilization of their clinical pharmacists, who are in many hospitals are disseminated into the patient care areas, oversee a lot of these pathways, make recommendations. We automatically change some of our medications from IV to PO. If patients have nausea and vomiting, pharmacists can automatically change it back from PO to IV. And we monitor these 7 days a week. So here's a couple of examples. These may be a little hard to see, but these are just just a few examples. We don't have any magic bullets here in Plymouth, but our order sets are even in flex of being changed as we speak. This is just we have the Meditech system here in Plymouth. This is one of our older versions looking at our ED order set, and our ED order set, pain order set is the same for our in-house order set. Some institutions have done away with the combination of opioid and acetaminophen. We still utilize those for some of the patients that may come into our ED and are discharged on those medications. So we still have those available. As you can see, we have IV non-steroidals available. We have IV acetaminophen available. And we have to assure that when ordering opioids or ordering any analgesic that you're utilizing a pain scale. You can't just say PRN pain. I will get into this momentarily, but Joint Commission just came and visited us about 6 weeks ago. I have the fortune of accompanying the physician surveyor along with our CMO to all the sites. I had to give a presentation on our pain, stewardship, and antimicrobial stewardship committee meetings. And all of these things that I'm showing you today were well viewed by the surveyor, and actually gave us kind of a plug on their discharge summary of the good job that was being done by all of our providers. So having this available is critically important, as I said, ED and as well as inpatient. This is just an example of our orthopedic preoperative other med order set. Once a patient is scheduled for a procedure, that the physician or their PA from their office can enter these pre-op medications, which are verified by the pharmacist, days in advance to the surgery. We've even updated these medications that celecoxib, as I said, the COX-2 inhibitor, we now give 400 milligrams of that preoperatively. Oxycodone slow release, although it is here, we followed, I've had PharmD students collecting data, we followed a couple of hundred patients, and some of the patients that, a large percentage of the patients that received this preoperatively, even though that they were younger patients, still had a lot of post-op nausea and vomiting. So we actually, this is rarely if ever ordered. We utilize pregabalin and gabapentin, which is not here, not on all of the patients, but that has had some benefit. We've been giving a gram of IV acetaminophen preoperatively, as well as scopolamine, and we do utilize liposomal bupivacaine. Once again, there are many places where the analgesic cocktail is utilized by a lot of institutions. We feel that utilizing this sterile product the way it is has been developed, although a little bit more costly, we've received tremendous benefit. So still in flux of, and we've also added PO tranexamic acid as an aside, which is worked extraordinarily well rather than IV or topical. And then finally, postoperatively, as I said, one of the things, as you can see through this maze, is that we utilize IV acetaminophen postoperatively, 1 gram every 6 hours, which automatically changes to oral 1 gram every 6 hours thereafter. The physicians can order oxycodone if they wish, and also we do utilize Celebrex every 12 hours. So once again, and more or less, the patients will utilize some tramadol postoperatively, but the utilization of post-op opioids for many of these total knees, as well as total hips, is dramatically decreased. Another caveat of our clinical pharmacy service and from our pain stewardship committee is that we have monitored the use of naloxone. So, if you're looking into in your institution, that Joint Commission would be tremendously interested in how are you assuring that your pain management and the agents that you're utilizing are really effective or ineffective or causing more adverse events. Well, we actually put together this monitoring program in 2014 before it was kind of cool to do that. And what we did is we had a DR report, as you can see down below. This prints out 7 days a week. Any patient that we administer an opioid to in the hospital and they're administered naloxone in the same stay will print out on this report. This report I sent to our clinical coordinator, who he puts together a report. We utilize the adverse drug reaction report from the Joint Commission 2012 sentinel event alert of the high risk for respiratory depression. We look at and this is not meant to be punitive. This is meant to be, how could we have done better? Was it a medical patient that came in through the ED? Was it a surgical patient, which we may have given too much opioids, which resulted in an adverse event? Since 2014, we've averaged in 2015 through 2018 about 10 reports a year, which is extraordinarily low for a hospital of this size. But as I said, we review all of these reports at every one of our pain stewardship committees. We filter that information back to the provider as well as the service. And as I said, once again, this is utilized for, how could we have done it better rather than punitive as we move forward. So redesigning pain management, just briefly to go over the Mass Hospital Association. Mass Hospital Association was put together in 2014, put together the Substance Use Disorder Prevention and Treatment Task Force. We had two initiatives that we looked forward to. In February of 2015, phase one was a lot of ED initiatives that were approved for patients coming into the ED, whether they administered non-opioids or opioids and issues like that. In March of 2015, we developed the in-house recommendations for the use of opioids. The co-chair of that particular committee was the chief of anesthesia here in Plymouth. I worked very closely with him. There were probably about 26 different initiatives for that particular group of recommendations. We select and there were representatives on this committee from all over Massachusetts, from the tertiaries down to the community hospitals. We selected the education around pain. So with several providers from Mass Hospital Association, myself, and the chief of anesthesia, we actually figured that what we wanted to do is develop a toolkit in order to train practitioners of all of the elements that I just discussed of implementing multimodal analgesia, reducing the use of opioids, and reducing adverse events. So that being said, we partnered with Mallinckrodt, and a lot of folks, when you take clinical committees from a hospital and you partner with pharma, some folks look down on that. This was truly a collaboration that had truly quality and decrease of adverse events in mind. As I said, experienced specialists from Mass Hospital Association. We had 12 specialists from here in Plymouth, as well as some of the quality folks from Mallinckrodt to develop a toolkit. That being said, we were able to develop the Pain Stewardship website, at painstewardship.com. This was a international press release, which was sent out in June 21st of 2017, which highlighted our collaboration. We're truly proud of that. As I said, this is just an example of the folks that we had that participated in this evaluation. There were numerous parts of the toolkit there were brochures for patients, there were PowerPoint presentations, which really enhanced this particular website and this toolkit. As I said, you can go to www.painstewardship.com. If you click on the acknowledgments, you'll see that there is acknowledgement to the Mass Hospital Association for being the clinical experts. If you click here, I will not do this now, it gives you a 2-minute video which explains all of the elements of this website. I strongly advise you to go to this website. It is free, and you can utilize a lot of the brochures and resources on this website. So how do we put this into practice, this whole process? Well, it has to be a redesign across the whole system. We need multidisciplinary input. We have to make sure that we include our quality and safety folks, as well as educating our senior leadership back to the basics for safe medication or safe pain management. We have to impress on our patients and educate our patients is that it's not really a number, it's achieving a functional goal. If you look at We want to establish pain stewardship committees. I'm sure that a lot of you have those in place currently. Recognize that all patients are at risk and that it's mandatory and universal admission and an ongoing risk assessment of all these patients. We want to establish and monitor guidelines for opioid administration and consider the establishment of specialty units for there's people call them falls units or elderly care units, as well as our post-op care units. Standardizing treatment for all patient populations, and this is critically important, which is highlighted on the website, is provide practical non-pharmacologic methods of pain management, repositioning, elevating arms, ice. This was in a brochure that we had created, which is called Managing Pain After Surgery. Talks about educating patients for their expectation of tolerable pain. We have also implemented a comfort menu, which is at the patient's bedside, which actually highlights all of these, and it looks like a food menu. And we're creating a brochure around that to educate patients of the importance of non-pharmacologic methods of pain management. We also want to do an institutional assessment checklist. So if you don't have these things in place, you should look at, do you have standardized order sets? Are you utilizing multimodal analgesia? And there are multiple steps that you can visualize on the Pain Stewardship website. So quickly, putting together a Pain Stewardship Committee. As I said, it's a mandate from the Joint Commission as of January 1st, and they will be evaluating you and all the aspects of pain management. Our particular Pain Stewardship Committee, we review all of our pain management practices. We review the new evidence-based guidelines. If there is a change, we implement the new changes and external recommendations. If there, if CMS puts up a recommendation, or CDC, or it comes from Joint Commission, we look at those recommendations and we change as appropriate, and we disseminate all that information to our medical staff and the ancillary services. One of the important things when the Joint Commission came to see us this 6 weeks ago is that we have instituted pain stewardship breakfast rounds. So monthly we have a different specialty provide a presentation on pain management. We've had our surgeons present, we've had our nursing staff present, we've had PCPs in the community present, and so therefore these have been very effective in educating our staff. So educating staff and patients is critically important. Our first meeting was May of 2016, so as I said, there's a very diverse group of folks on our Pain Stewardship Committee. As I said, we have pain stewardship, we have PCPs on our committee, we have nursing staff on our committee, we have our patient care advocate on our committee who actually brings us reports on HCAHPS scores monthly, which is very informative for our presentations. And then finally, one of the most important things that we've done, we have our director of social service at our committees. We've developed care plans for our substance use disorder patients. So I'm not sure whether, I presented in many different organizations across the state and in New England, and we can't call them frequent flyers to our emergency department any longer. We call them familiar faces. I was corrected by our chief of our director of social work. So what we do is for patients who continuously come to our emergency department who are pain seeking, opioid seeking, we actually sit down with them, we get their PCP involved, we have the attending physician involved, social work, the patient, and we put together a plan of these are the things that we will do, what we will do for you, and these are customized for each patient. And the things that we will do for you is that we're trying to get them into a program to alleviate their withdrawal symptoms. These are the kind of pain medications that we will give you. These are the follow-ups that we will give you. And this is identified for the provider so that an ED physician and even a hospitalist that's admitting the patient will see these care plans. Now, on the flip side of this, and when the pendulum swings too far to the left, we have patients who are on specific pain regimen, opioid pain regimens that when they come to the emergency room, we want them to receive the care that they need. We don't want them to be denied the opioids that they should be receiving as seen by a specialist. So we have a couple of patients that come through here that have complex pain syndrome that we have developed care plans for them also. We've actually developed the plan with the patient, with the specialist, so that it actually identifies the patient. The patient can tell the ED provider that they do have a care plan, and ultimately they can receive the most appropriate care when they get to the hospital. So there are pluses and minuses with these care plans, but these care plans have been very beneficial and identified as these patients are admitted. So back to the paradigm, and this is, my final slide is that, as I said, we have no magic bullets here in Plymouth that, we have to change the way that we care for patients in pain. We have to really educate our patients, across our systems. We would want them all to get the same message from, all sites of care that, you can have tolerable pain. We can treat you with non-opioid analgesics. We can treat you with non-pharmacologic methods to improve your pain. For different surgical procedures, there are different methodologies on how we give you pre-medications and post-op medications. Ultimately, we want to make sure that we're delivering a high quality of care. It's safe for our patients, and then ultimately that their experience is a good one, and that they feel that they're getting the highest quality of care when they come to our organization. So with that, I will thank you for the time. And if there are any questions, I give it back to Ayala and Wemi. Ayla, I'm sorry.
Thank you. No, thank you so much, Jimmy, for that fantastic presentation. And like you said, we will now begin today's question and answer session. So please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we'll try to get through as many as we have time for today. We've already had several questions come in, so I'll go ahead and get started with those. And the first question for you, Jimmy, is this attendee says there is a lot of pushback from the C-suite for use of liposomal local anesthetics due to cost. And they want to know, are there any studies that compare cost to effectiveness versus standard canes?
Well, there are actually some studies that support the use of the analgesic cocktail, which it varies a little bit different depending on which articles that you read, but there are 3 or 4 different agents that are kind of drawn up and put together and injected intradermally into the surgical site, as compared to liposomal bupivacaine or Exparel. And we looked at those particular studies, and some of those studies actually support that you can receive as much pain relief with those particular agents. But we feel strongly that, although the liposomal bupivacaine may be approximately $300 compared to the preparation of the cocktail, the elements of the cocktail may be less than $30 or less than $50. But, the way we look at it is that the liposomal bupivacaine is a sterile product that we are bringing to our OR. There's not a lot of manipulation of different vials, different amounts of that cocktail that have to be mixed together, timing and preparation for it to be mixed together, potential for contamination when they're being mixed. And ultimately, we feel that the benefit, once again, the global value outweighs the cost. And so I've read all of those studies that actually support utilizing the cocktail, but our post-op surgical site infection rate for our orthopedic service, knees and hips, extraordinarily low, like 0.4% or something like to that effect. As a card-carrying member, I've had both my knees replaced since June. And I received Exparel in both instances. I received non-opioids. I received IV acetaminophen, PO Celebrex, a short-acting spinal. I was up and walking with physical therapy at 3 o'clock that afternoon, 7 o'clock that night, and discharged within 27 hours of coming in the hospital. So we feel, I do see that you will get some pushback from your senior leadership in some instances. We just feel here that until a better agent comes along that's totally sterile that we could utilize, we don't want to make any changes because of the outcomes that we're seeing with the process that we have in place.
Thank you so much, Jimmy. And we want to go ahead. It looks like we have time for one more question. And this person wants to know, how are you measuring pain?
Well, we utilize the pain score. We have the pain scores, right? Wong-Baker pain score, which we utilize the scale of 1 to 10 throughout the hospital. Obviously, in the intensive care unit, we're looking at the behavioral pain score for those patients who can't speak. But ultimately, for all of those patients who can speak, it's a pain scale of 1 to 10. It's assessed by the nurses in all areas. We're utilizing, 1 to 3, 4 to 6, and 7 to 10. We, as I said previously, as we're measuring those, we're actually, I've had my PharmD interns collecting data on a lot of hips and knees and looking at, at the, pain scale every 12 hours for those patients post-operatively, receiving good results with the non-opioids, as I stated before. But that's how we're measuring pain. And as I said, what's important and when the surveyor came most recently is that they're looking at not ordering any agent that says just PRN pain. If you have other agents that you've already, a surgeon maybe or a physician has ordered in the pain scale 1 to 3, 4 to 7, 4 to 6, and 7 to 10, and they add, say, Toradol for pain, that they have to do a stepwise approach of when that element should be added so that the nurse is aware of when it should be added. That's just a kind of a caveat of what the Joint Commission surveyor was looking for. But that's kind of how we assess our pain here and across our organization.
Great, thank you so much, Jimmy, for that response. And we've had several more questions come in, so I'm looking through to kind of see which ones we would like to touch on today. And I think we'd like to wrap it up with one more final question. And that is, do you see any noticeable differences between PO acetaminophen versus IV offer meds?
So how we feel, and this has been from day one, this has been the kind of like the #1 question, and what we've used here in the literature, there are multiple different papers which sway to the left and sway to the right. I can tell you from our experience here is that, and I can tell you for the medical and the surgical patient. For the surgical patient, we've opted to use 1 gram IV preoperatively and 3 doses every 6 hours postoperatively. In some instances, we'll only give 2 doses postoperatively every 6 hours, and then we automatically switch to oral therapy. In those instances, in say some of the total knee or total hip patients, that they're on an oral diet by the evening of their surgery, and therefore we've switched to PO acetaminophen. And once the patient, in the critical period about, how many doses to give in that pre and post-operative period, once again goes back to the slide that I had showed before to assure that the patient's GI motility is intact. Now, if it was just straight IV to PO, it depends on the, the IV bypasses the first pass effect. And so therefore, we want to make sure that that drug is working within the first 15 minutes. Now, the stresses of surgery and the additional administration of other opioids will decrease gastric emptying time, decrease the absorption of oral acetaminophen. So therefore, we wanted to make sure, as I said, we've had extraordinarily good results giving, restricting it to those 3 doses or 2 doses postoperatively of IV acetaminophen. That's what we're looking at for the surgical patient. For the medical patient, our ED physicians, if an elderly patient comes in, falls, maybe it's not a broken hip, but we don't want to give them PO acetaminophen in the ED. We'll give them 1 dose IV of IV acetaminophen, maybe a non-steroidal depending on the patient. But then ultimately when the patient goes to the floor, sometimes the hospitals will write IV acetaminophen Q6 hours, PRN for pain. If the patient is taking all other agents orally of that time, we automatically change that, the pharmacist, to PO. We feel if you're taking all of your other agents at that time for a medical patient, that we can convert it to PO with the same result, and obviously a gram. But ultimately, if the patient, for some reason, is not taking oral therapy, the pharmacist can convert back to IV. That's the way we monitor and maintain, the clinical pharmacist in the utilization of the IV versus the PO. But I would just be careful on that caveat of GI motility for that surgical patient, giving it orally.
Well, thank you so much, Jimmy, for that response and all of your insight today. That is all the time that we have for today, but I want to once again thank you, Jimmy, for the excellent presentation, and to Mallinckrodt Pharmaceuticals for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you all. I appreciate your time and spending with me at noon. Thank you.